Hi everyone, it's Mohamed Draz again, and this is the Brain, Spine and Beyond video podcast. This is your place to learn, innovate and invent. Today is our fifth episode of the video podcast. If you haven't watched the previous podcast episodes, please, you can watch that through our YouTube channel. Today we have a special guest. We have Mr. Paul Grundy. Mr. Grundy is a neurosurgeon in the University Hospital Southampton. He's also the Chief Medical Officer of the Trust. He has been in many leadership positions during his career. He was the past president of the British Neuro-oncology Society. He has also been an executive committee member of the Society of British Neurosurgeons. And also he has been the National Transformation Lead for Neurosurgery for NHS England. He has been awarded multiple leadership awards. In 2012, he was voted by the HSJ as the UK Clinical Leader of the Year. And also he was selected as one of the top 100 most influential medical leaders in the UK, and also has been awarded the National Clinical Excellence Award 2 times during his career. Mr. Grundy, thanks for taking the time to come to the podcast. It's a privilege, and it's very nice to have you.
Yeah, thank you for inviting me. It's a pleasure and a privilege.
Thanks. So if we start from your current role as being a Chief Medical Officer, because that's an interesting one, because to my knowledge, I don't know anyone as a neurosurgeon who has been in this position before as a Chief Medical Officer. It's always kept for medicine physicians. So it's quite an interesting combination. So how did you end up being a Chief Medical Officer for Southampton hospitals, the university hospitals?
Yeah, thanks, Mohamed. Yeah, it's a good question, and one I ask myself most mornings. In actual fact, how on earth did I end up here? But I have to say up front, it wasn't necessarily a deliberate plan on my behalf. I know, and maybe it's more commonplace now that people, even at early stages of their career, might imagine themselves going into a leadership journey, and that was never the case for myself. It was more an accidental phenomenon. I don't come with a lot of leadership training. I learnt on the job, but I can sort of explain how I got here. And as a neurosurgeon, I think it is unusual. I certainly know one other neurosurgeon who did this role or shared this role in another hospital with one of his colleagues. But and I can see why perhaps a lot of neurosurgeons don't go into a role like this, because most of us love our patients and we love operating. And these roles have become so onerous, haven't they, that quite often the implications of taking on a role like this are you'll have less time with your patients and less time operating. And in actual fact, my predecessor in this role here, he was a physician, did drop all of his clinical activity to take on this role full time. And that was something I should say up front that I wasn't keen on doing for a number of reasons. So I've been lucky enough to keep my operating list, which is every Wednesday. So it nicely breaks up my week into 2 halves with a place of safety in the middle in the operating theatre. That's my safe space still. But to be honest, that gives me a break, but it keeps me grounded. And, whilst I'm the Chief Medical Officer, I don't want to be the person making or contributing to difficult decisions in the hospital that might land badly with staff. I know how it feels to be a surgeon, a doctor and a caregiver in this hospital, because I still am one of those people. I still have a waiting list. I still have all of those pressures about lack of beds and trying to get my elective work done and all the rest of it. So I think it helps you stay grounded. It makes it easier to be credible as a leader if you're also one of the team. Not to say that you can't do those things without being an active clinician, but that was my preference. And I still love my day job, as I see it, I suppose, as a neurosurgeon. I spent my whole life wanting to be a neurosurgeon, training to be a neurosurgeon. I wasn't going to give it up that easily. So I could perhaps go back then to the question, which was around, sort of how did I end up as Chief Medical Officer? And really that, as I said, was a bit accidental. But if I look back and realise why I ended up going through various levels of leadership. So firstly, within my care group of neurosciences, and then we have a structure, we have a divisional level and then a deputy medical director. And through that sort of, I think the reason I started off on that journey was when I started as a consultant in my own department in this hospital. I saw a lot of opportunities for us to do things differently and to innovate. And whilst I really struggled with that, and maybe we can discuss that later, I managed to get through a number of transformation programs in the first 2 or 3 years of being a consultant here. Partly selfish because I wanted to be more efficient and more productive because I had patients that I wanted to treat and we struggled with beds and all those other pressures. So we had to make some significant pathway changes. And so long story short, that work and that innovative work and the transformation work we did, I suppose, got me thinking, I quite like change and I quite like the idea of improving things constantly and making things better for our staff and for our patients. And I suppose when you manage to achieve a few small steps like that, other people notice, don't they? So actually, if you do make a difference, people notice and say, well, actually, we think there may be some opportunities for you to contribute more to this organization. And before you know it, you work your way up through those ranks, don't you? And there have been a number of occasions during that process where I tried to duck my head down, actually, but maybe not fast enough and maybe not far enough. So, for example, when I went from being a clinical lead, which you could do in just a day of the week and still keep going with my normal neurosurgical job, the next step up to divisional lead for me meant I had to give up half of my clinical week, basically, and that was a really tough decision for me to make. I was still, I would say, quite early in my career, and I wasn't keen on giving up anything clinical, but I had to find a way of making that work. I did find a way, and often I guess a message for people looking at opportunities is sometimes you make your own opportunities in life where you make things easier for yourself. So I realised I would have to give up the on-call because I wasn't around to look after some of the sickest patients in our unit. I found a solution by working with my colleagues. I'm incredibly lucky that the team of consultant colleagues here in Southampton were very supportive and also came at a time where the department expanded. So one person coming off the on-call rota, it wouldn't compromise the others in the department. But the other thing that I did that I think was a benefit to me and the department and hopefully neurosurgery a bit more widely is we brought in a fellow, a Royal College of Surgeons Neuro-oncology fellow. In fact, it was the first RCS senior surgical fellowship. It was the first scheme in neurosurgery in the country. And that has been invaluable, I think, for me, because they're there when I'm not there, and they're essentially learning how to do my job, but with me as a shadow in the background. So I think it's been a really positive but a tough experience for a lot of trainees coming through wanting that fellowship experience. We've kept that going for the last 10 years, but I couldn't have survived without that opportunity. So I've been lucky. I've had good people around me who supported me, and then accidentally I've fallen through various phases into the place where I am now as a CMO.
That's quite interesting. If you can tell me a little bit about how's your day-to-day work in terms of being a CMO. So what do you actually do, like on a day-to-day basis? How's that different from just being a neurosurgeon for the whole week, or even, as you said earlier, like a clinical lead, maybe try to do these activities in one day and the rest of the week as neurosurgery?
Yeah, so fundamentally my Monday, Tuesday, Thursday, Friday is fully dedicated to the leadership role, and that's one of the things I like about it. I guess it's a very varied role. So you have your finger in a lot of pies, and those pies nowadays around quality, safety, governance, sitting on a board, internal things in the organization, but also increasingly now those collaborative pieces outside the organization. So I will have meetings with the NHS England Southeast Regional Team, for example. We'll have similar meetings now at ICS, at ICB level. There'll be national meetings we get called to. So there's a lot of opportunity, and consequently, the answer to the question of what do I do all day, every day is a lot of the time I sit here staring at this very same computer from this same seat, which is sometimes a bit painful. I guess what I try and mix that up with getting out and about and meeting people, because whilst I'm there in my clinical service on a Wednesday, and I also support the MDT, by the way, but otherwise, I'm looking after a whole hospital. And I went up through the ranks in a certain corner of the hospital in specialist services, but there are a lot of people when I started off in this role that I didn't know, services I didn't understand. So I have, for example, this afternoon a walkabout around the maternity service with the team over there. So we'll spend a bit of time, try and get that in every couple of days, walking about different parts of the hospital, addressing, meeting people, talking through those processes. We've got a lot of transformation work going on here, as they have elsewhere in the NHS. So we have 3 big programs of work, 2 of which I will be the responsible executive for, and that will be more on the elective side, so operating theatres, outpatients, and so forth. So transformation pieces of work like that we lead and support through the hospital. I would say, I guess my day is quite varied in terms of who I'm meeting, but there's also quite a significant element of stress involved in some of this, I would say, and a different sort of stress from neurosurgery. It's often that the problems that arrive on my desk are the problems that no one else has been able to solve. So they're often challenging issues that and I have a few of those, as anyone would in my position, whether they're related to individuals or teams or other financial or other scenarios that are sat with me, struggling with my colleagues and peers to try and resolve. So it's a really challenging job, and I guess that's the other reason. Why did I go down a different route after so many years of neurosurgery? I did like the idea of fresh challenges. I think after, you've been doing something for 15, 20 years, you get into the sort of comfort zone of I can do this. And there's something about that sort of wanting to grow as a person and develop yourself and explore other opportunities that, whether your bag is research or leadership or whatever it might be, there are opportunities out there for different people. And for me, leadership came about as an opportunity, gives me a bit of variety. And, that aspect of it I really enjoy and embrace.
And as you mentioned now, saying about the difficult problems that comes to your desk, if there is, one problem that you faced during your leadership position, either now or before, that was really difficult, if you give us like an overview of that, and why do you think that was a difficult decision? Or how was it difficult, and how did you manage to sort it out?
Yeah, I don't know. I mean, I have a few live examples. You have to be careful about what you say, don't you? Because some of these can be identified back to teams or individuals. Yeah. Look, in times of COVID, we had to go into a slightly more command and control situation, didn't we, across the NHS, as you do in a time of crisis. And that meant you had to make some big decisions, and big decisions that maybe without the degree of consultation that we'd normally have, because, we try and make big decisions, don't we, with people, not for people. So on the whole, when people come to me with a problem, I ask them for their ideas and what the solution might be. I try and facilitate rather than direct, because that works better. But there are situations, aren't there, where you have to make big decisions, and not always are those decisions popular with everyone. When there's a conflict and there's one team with one opinion and another with an opposite, at the end of that situation, however hard you try, there will be one group of staff who, I wouldn't say hate you, but don't appreciate the decision you've ultimately had to make. Some of those involved moving our intensive care units at times of COVID, when we had to very rapidly make decisions on what we did. We made those decisions with as much consultation as possible, but there were very conflicting views about, which team should move into which area as those areas expanded. And yeah, ultimately, sort of when the buck stops with you, or with you and a small number of exec colleagues, a decision has to be made, and you have to live with that decision. So yes, there have been some very challenging moments related to things like that, and with people. Likewise, having the joy of looking over grievances of staff members against one another, that, again, however hard you work with those people to support those people working together and get to a satisfactory resolution, my lived experience is one side of those two parties is always unhappy with you and the decisions that are made, however carefully you try to make those things. So that's the reality of being in this role, which actually probably means it isn't for everyone. Even sometimes I wonder if it's for me, because you do feel like as time goes by that there are consequently significant numbers of people who think on occasions you've made a decision that they don't agree with. So yeah, try not to put yourself in that position. Try to work with people, but that's an easier thing to say than do some of the time. And we've got some really challenging teams that we're working with at the moment. And I would say I'm lucky from a neurosurgical perspective to have an amazing team of colleagues. And that has made me realize when I've seen the challenges they have in other areas, how important it is to know each other, understand each other, work professionally with one another. It might be in a team that you're not all of the best of friends, but if you're professional, courteous, and kind to one another, that makes for a much safer, much more high quality environment for delivering healthcare. And it makes your life a good place to be. As I say to a lot of trainees who are coming here looking for jobs, they realize when they've rotated through departments, which departments they want to be part of. And usually that's because people get on with one another, are respectful to one another and support one another. And of course, the opposite applies when you haven't got that psychological safety. For example, I'm having some conversations today about M&M meetings and multidisciplinary team meetings. They should be a place for support and learning, shouldn't they? But sometimes they've got the potential to be quite confrontational spaces too. And those are some of the really difficult challenges when you have a group of people, perhaps who don't see eye to eye, and that gets into a really difficult place. There can be really difficult problems to solve.
Yeah, that's. I think it's a lot of challenges, to be honest. How do you see? I mean, sometimes you see some leaders or surgeons that they kind of defer the decision to someone else. So, like, they don't want to be in that position that say, okay, this is what's going to happen, or push the decision in one direction. And basically that ends up that it goes to the higher level hierarchy, within the hierarchy of leadership, to someone else and someone else and someone else. It's just like passing the responsibility of making that decision, just mostly I think because of being afraid of making wrong decision. Do you come across like a lot of these decisions that comes to your desk at the end or to your email that just it happens just because someone else didn't want to make that decision, and you are the person that you have to make that decision?
Yeah, I mean, I think the answer is sort of yes and no, if I may. In that, yes, those situations do arise and do come to me. I guess, do you know what's been difficult for me is that I grew up as a neurosurgeon, and whether you're a registrar on call or a consultant on call, you are making snap decisions, literally life or death decisions, aren't you, on a day-to-day, hour-to-hour basis? Live or die decisions. Do we treat this patient? Do we not? Do we bring them now? Do we not? And whilst you might do that probably in consultation only with a small number of peers, registrar talking to his consultant or whatever, I guess I grew up in that environment of I was the decision maker. And one of the difficult things for me has been in the leadership position, that is just not the way it works on the whole. Because if I'm just making decisions, more often than not, I'll be wrong. And so what I try and do now, and I find you're right, people come to me and say, we can't decide, we're having a debate, or I want you to make a decision. And I hinted at this before, is that I'm a facilitator, not the decision maker. I try and empower people to say, well, look, mostly when people come to you, they know what they want to do and they know what they think is right. They just want to talk that through with someone. So I have to now, which is sort of against my background, I suppose, say, well, look, what do you think is the right thing to do? And what are the pros and cons? And what do you think is the right way forward? And often when you do that, and it sounds simplistic, but people have got the solution to that problem. They know what the answer is. They just want a bit of to talk it through and support it. And look, teams don't like to be micromanaged and have people tell them what to do. So I try and lead. So I find that my style of leadership very much is as a facilitator and not as a micromanager. And that I think it's well established that you get the most out of your teams if you work in that way, isn't it? I think the opposite, I suppose, to some of that I've seen recently is in my own surgical specialty, neuro-oncology. We had a very small team. There were two of us, and one of my senior colleagues retired a few years ago. We now have three new colleagues in that team. All have been appointed in the last 1, 2, 3 years. So younger colleagues. We work really well together as a team. But of course, I've been doing this for 20 years, haven't I? So I've made all the mistakes that they might be making if they're not careful. And I've learned from some of those mistakes. So they will quite often come to me or us all as a team and say, I'm not sure what to do with this patient. And in that situation, I don't mind sharing what I think I might want to do because I've been there, done it, and got the T-shirt, but also messed it up on more than one occasion, I'm sure. And I think, but there's a way of working that through, because again, most of those people know what they want to do. They just want someone else who's been there before to say, yeah, I agree with you. I think that is the right thing to do, just that bit of support.
Got your point. So not just in the UK, but I think across the world, a lot of the doctors are complaining about the disconnection between the management and the rest of the clinical team. And that's something as is kind of a common theme when you talk to clinical teams across the NHS at the moment, is that they feel that there's management out there or up there and there is clinical team and there is no connection whatsoever. Why is this, and how this problem can be solved? Is it the problem of the managers? Is it the problems of the clinical team? Is it a problem of someone else?
Yeah, look, I don't think it's anyone's fault, is it? But I can see how and why that happens. You know, when I sit in some of our trust executive committees or board meetings, it's funny. So look, we had a big trust executive committee meeting yesterday. So this is maybe 20 or so senior leaders in the organisation, and we had a big discussion about our headcount in the organisation. That is how many employees we have. And you might know that NHS produced a workforce plan, didn't they? Only just over a year ago, 2023, I think. And in that workforce plan, they said three things. Try really hard to retain your staff. You need to recruit more staff, and we need to train more staff, in recognition that there aren't enough staff in the NHS. And that's how it feels to most people out there on the shop floor, as you know. Now, if you fast forward now to where we are at the moment, we're being told as an organisation by the government and by NHS England that we don't have enough money for all of these staff. And in fact, we've grown our staff at too great a rate than we can afford. So we've now been told we actually got to rewind and go back and start actually losing some staff as part of that process, and maybe letting some staff go, and which feels to me very uncomfortable. But let's just say the conversation that played out in our executive committee yesterday was one of, as an organisation, we have got a handle of this, recognising those challenges. And over the last year, instead of that 20% increase we've been seeing, we've held our workforce flat. Now, we haven't reduced it because we didn't think it was safe to do so, but we've held it flat. And so yesterday, almost felt like an observer in this meeting, when essentially people in the meeting, we were congratulating one another for holding the workforce flat and talking about the next stage, which might be some people, some members of the workforce being let go. We've been told, for example, that we need to get rid of a third of some of the back office staff in some areas, which you'll know, the back office staff make this hospital work and keep it safe, as they do everywhere. So that really worries me. And so, but we sat there in our meeting with everyone congratulating each other for this successful achievement of holding the workforce flat. And I just struck me at that moment in time, because, as I told you, I am still an active clinician, and I'm out there on the wards and in theatres where people are worried about the workforce, that we've probably got 13,000 other people in this organisation who would not be seeing that as a success. They would be seeing that as our failure to support them in some ways. But we have to find a balance, don't we, about living within our means. And it's not that it's anyone's fault, but there is something about how we get clinician engagement when we're the management team. And I think one of the most challenging roles you can have in an organisation is where you sit in a leadership position, whether you're the lead for a specialty or a department. You've got to be able to represent the views of your department, haven't you, upstream to the senior leadership. They need to understand it. But equally, you've got to help in that process of making it clear to everyone why difficult decisions might have to be made. We have got no money. We can't afford to do these things. How can you help us solve those problems? So those are really difficult roles, because you've got to have your foot in both camps, actually. And what happens if you go too far to the management side is, I know what happens. All your clinical colleagues say you've gone over to the dark side, don't they? You've sold your soul to the management devil or something. So I think they're really difficult things to do. But again, one of the reasons I try and keep some clinical practice, keep my feet on the ground, is I know how difficult it is out there, because I am one of those people really struggling to deliver the work that I want to do for my patients. And the good thing for me is I can then sit there in a trust executive committee meeting and say, hang on a minute, everyone, I know we're celebrating this as a success, but there are people out there and we've got to think about how we work together. It is a really difficult challenge. We have, I think, 950 consultants in this trust. And how do I keep those 950 people engaged, that's still work in progress. It's difficult. Yeah.
But again, to your point about this getting clinicians engaged, I have seen so many clinical leads that are sending out their resignation from being a clinical lead. For one reason is they say, okay, I mean, we have been through these meetings, these engagements and everything, and we have plans. We end up multiple discussions with management and nothing happens. Again, I mean, do you think that the clinicians or clinical leads need to play more active role in implementing those changes? How can we bridge that gap? It's just because that leads at the end to frustration from the clinical lead point of view or the clinical team.
Yeah.
Plus, from the management side, you end up that nothing is happening or no change is happening. I know that it's difficult. It's a difficult question and it's a difficult situation because you have limited resources.
No, it's a good question, Mohamed. I think, do you know what? The people who've got the solutions to the problems that we have are our teams who are out there. They're not me. I've had my good ideas in years gone by. I implemented them in my own little service, but the people with the ideas are the people out there, and it's how you then engage them to deliver on that. So I guess my role or our role as leaders is to say that this is the context we're working in. We're going to have less money next year. We're going to have less people because that's just the reality of the world we're living in. How can you then help us do things differently? It can't be going forward. One of my messages is we can't just keep working harder and harder and harder and doing more of the same. We have to transform and do things differently, don't we? And that, is something that sort of interests me because I've always been a bit like that. As I mentioned from my early neurosurgical career, we haven't got enough beds. Why haven't we got enough beds in neurosurgery? Because we don't use them efficiently. So let's go to day of surgery admission. Let's introduce day case surgery. They're all things that are clinically led. Provide clinicians with a challenge and ask them to help you work through that challenge and a context, yeah? And there are some teams and some managers who are better at doing that than others, but that is where the solutions are coming from. And that is exactly what we're going through at the moment, because we know the challenges for next year that we've been set across the organisation and across the NHS almost feel impossible. And that is, we have been told financially you must live within your means, i.e. you must break even financially. And everyone is running a massive deficit at the moment. So that feels difficult. Furthermore, we've been told you must keep doing as much elective work and more than you did last year. That's already, by the way, 25% greater than it was before COVID. So we're already doing loads more work over the last few years. And urgent and emergency care must be kept safe and effective. So those are the three things we've been asked to do. Now, you might say, and I might say, when I look at that, well, that's impossible. I can't do all of those things. All I can really do is go out to my teams and say, this is what we've been asked to do. How can you help me work through some of those challenges? And we've done exactly that last week. So we have now got a short list of transformation projects that have come from our teams that we'll work through with our teams that will try and help us meet some of this challenge. But it's not going to be things from me. It's not going to be top down, me saying you must do this and that and the other. It might be me dropping some ideas in the minds of people about maybe running outpatients differently or theatre projects that we've learned from another hospital. They've done something effective, but it's then down to the teams really but how you get them engaged in an environment post-COVID where a lot of people somewhat demoralised, aren't they, by the state of the NHS and the environments that they're working in. That is the really, really challenging bit that I can't pretend to have all the solutions to, but it can't be top down, can it? It can be, we give you the context, we give you some ideas, and then how can you work with us to achieve some of these things?
And do you think that doctors or surgeons being in a management role, not just a leadership role, like being the organizations or the healthcare systems to be run by doctors, do you think that would be better than run by managers, which is the current situation, not just in the UK, but again, the US and other places around the world?
I think it's well established. So first of all, there are lots of, every consultant in the hospital is a leader of their team, aren't they? So that there are obviously leaders at every level, specialty leads, and all the way up to people like myself. It is imperative that we have as many clinical leaders in those teams as possible. And I know, because I was asked to support and look at a review that was done actually by a neurosurgical trainee, another part of the country, who did a piece of leadership work because she'd gone on a leadership, one of these national leadership training opportunities. She'd done a piece of work on the effectiveness and success of organizations based on how many members of the board of that organization were medical or clinical.
Mm-hmm.
And there is a correlation. The more medical, clinical people you have leading a hospital, the better that hospital tends to do. And so that evidence base is actually out there, as you say. Is that the way, the reality of how many organizations work? No, it isn't, is it? But as an example, of course, in our executive team here, I am the only person who is an active clinician. But having people with a clinical background delivers better care. So I agree with you. It's a really important thing to do. And then how do we make these jobs attractive to people? Because they are stressful and they are difficult. They are challenging. Look at the context I just set. You set people an impossible challenge. But we do need people who are good leaders to go away, have some thinking, maybe do some training, and try and work with us on these things, because that will have a massive impact on the delivery of services. And you'll see that in all of the teams that I've tried to support who've been, let's say, failing teams or teams in difficulty. Often it's been due to lack of good leadership, if I'm honest. And where leadership works well, it really pays dividends. So absolutely, there's evidence for that. We need to support that. We need more people like me and you and others to think about leadership as part of their career in the future. And there are really good opportunities now. I know at least 3 neurosurgical trainees who've gone off on national leadership programs in the last couple of years. So people are realizing this and recognizing this. And one of the things I did, by the way, with the SBNS is we supported a couple of people each year to go on a national training program that was run through the Royal College of Surgeons in Edinburgh on leadership. And so I think there are people out there, and there's training out there now to support people. I'd really encourage people to look at that. For me, I missed that opportunity. It didn't exist when I was a trainee. I did what many trainees do. I spent 2 years in a lab doing a higher degree in research, knowing that I'd never wanted to be an academic. That would have been time much better spent actually doing some focused time on leadership, albeit some of my colleagues maybe don't agree with me, but I think that would be time for some people well spent.
Yeah, I've been through the program with the Future Leaders program of the Royal College of Edinburgh.
Yeah,
which was quite good. It was a 1-year program. Do you think that we might see, or about a neurosurgeon being a CEO of the trust rather than just being in a medical role? Is that something that can happen? Why yes, why no? Is that something that they can do or we can do as surgeons or as doctors?
Yeah, so they're increasing. I said there probably is an increasing trend for people like myself who've perhaps been through that CMO route to then become chief executives of organizations. So there are chief execs around the country from all different backgrounds, including medical, including nursing and so forth. So that is becoming, and I think that's a really important thing to consider. And I sit here thinking, well, what will I want to do in 5 years' time? Would I want to go down that route or a different sort of leadership route? I'm not sure. It is a different job. It is ultimately running a business as well as being clinical. And do we have all of those business skills? Not necessarily, but can you get trained and learn about those things? Yes, of course you can. So I think when that works, it works really, really well. And there are many good examples of that. And I think it is becoming a pattern, and I think a good pattern for the reason I mentioned before. Clinical leadership, or people who've been clinicians leading trust boards, deliver on the whole better outcomes and health for their organization. So I think there is an opportunity there to be tapped into. It might not be for everyone, but definitely a good opportunity for some.
And being in those leadership positions, a lot of them, what do you think are the top 3 skills that you need to have to be in a leadership position, or things that you have to develop to be in those leadership positions?
And it's probably softer stuff, isn't it? And I watched, I look back on my old self, and one of my colleagues years ago described me as being difficult. Someone told me I was difficult. That was when I was a senior trainee. And another one of my colleagues when I was a consultant described me as being very prickly. And basically that was out of my frustration of trying to deliver change actually, and finding it
Yeah.
quite difficult. And I guess what I've learned with time is how to soften yourself somewhat. And people talk a lot, don't they, about compassionate leadership. And I
Mm.
think that's something that most clinicians can get behind, because that's how we see and treat our patients, don't we? So
Yes.
reaching out to people, listening to what they have to say, responding appropriately to that, and taking appropriate actions. It's something about how we work with our patients. Actually, if you can start working that way with your um, management, leadership, clinical, and other colleagues in the hospital, again, well established off the back of evidence, isn't it, that that's an effective
Mm.
style of leadership? So I
Mm.
think that's one approach that I think is quite important, is just really being in that compassionate leadership approach. And the other thing for me, I mentioned this before, is don't micromanage people. Let people flourish, empower them, give them the space to work, coach them, support them, but don't suppress them. Let them come up with new ideas, try them and test them. So being in a more facilitating environment rather than that command or control sits
Mm.
more comfortably with me now than maybe it did in the past, but it is a better place to be, again, based on evidence. So I guess that's the kind of style of leadership now, isn't it? Setting the scene and the context for people, not telling them what to do, but supporting them through running some of these transformation programs, for example.
Mm.
I think that gives a flavour of what leadership probably needs to be about nowadays. It's not about being the boss and making, as we said before, not about making all the decisions and pointing your fingers and telling people off. It is about guiding, supporting, facilitating, being compassionate, getting to know people, trust and respect for one another. Those are the things that actually you realise as you get a bit older and wiser. Maybe because I've made, as I've hinted, those mistakes myself in the past, being that prickly, difficult person. But
Yeah.
hopefully, people wouldn't see me in quite the same way now. But maybe some would. But I'm hoping I've grown a bit as an individual. You just do, don't you? Because you work out for yourself what gets the most out of other people, and it
Yes.
isn't by bossing them about and being difficult.
Yeah. So, well, as we talked before the podcast interview today, I mean, we had a brief discussion about, and we touched upon the workflows, the pathways within the NHS, and how that leads to transformation. And personally, I'm a big believer in that. One of the main things that can help the NHS nowadays is creating better workflows and pathways. And you have been involved in a lot of these transformation programs.
Yeah.
Um, how can you convince people that these things can make change, creating those pathways and workflows? And if you can give us one or two examples of some of the work that you have done and how this led to transformation or a change within the NHS.
Oh, yeah, it just broke up there a bit. I think you said one or two examples, and I guess I talked through a very good example of something that a challenge that we faced here, and I've found it quite difficult to persuade other people of the benefits of something, even when you prove it. So, for example, one of those transformation innovation things I did as a younger consultant was we firstly embraced the concept of day of surgery admission for elective work, which no one used to do, okay, because everyone used to come into hospital the night before and stay in bed, and then it actually wasn't until I went and worked overseas in Australia for a year that I saw a different way of working. And there's a thing: go around and look at what other people are doing. Some of them will have brilliant ideas that you can steal. So most of these are ideas I've stolen from other people. But the next thing for me, from following on from day of surgery admission, was actually I think there are some operations that we can do in neuro-oncology. That's my specialist interest, that as a day case. And when we had that idea some years ago, I would say it was very controversial, not just with my colleagues, but with my colleagues across the whole country. So when I presented
Mm.
some pilot work on this, in actual fact, people literally shot us down in flames and told me, I was told in a national meeting, that people hoped I had a good lawyer because I was going to need them, and that I should abandon what I was doing. And the first thing I would say, that all that the lesson
Mm.
that taught me was, do not suppress innovation. Do not let people stand in the way of doing the right thing. The day case work for us started with biopsy and craniotomies. We published it a number of years ago now. I think, for me, the thought of bringing in someone for a biopsy for a brain tumor operation We may have lost signal there for a minute. Excusing the pun, but it's a no-brainer doing that as a day case. We do all of our biopsies as a day case, and I can't imagine that there's any logical rationale for anyone to admit a patient. We've done it, we've proven it, we've looked at hundreds of patients, as they have, by the way, elsewhere in the world. It wasn't my idea. It was pioneered probably in Toronto. We went there, we stole their ideas, we brought it here. One of my biggest frustrations is not that we don't have it working here, because we got it working here pretty quickly. We had a small team and we got it going, and it's been really effective. But trying then to roll that out nationally through some of our national work has been really challenging. Some units picked it up and ran with it. So, for example, Leeds, quite a forward-thinking unit, picked it up, ran with it. They, like us, we've probably got nearly 20 years of experience. They've got nearly 15 years worth of experience and data now. However, if you look at the number of units in the country that are doing this, and bear in mind, I've spent 15 years telling people about this and presenting and talking at national meetings, only a handful of units, even 20 years later, are routinely using day case surgery in neuro-oncology. And that, how do you persuade people? I've been through a bit of a journey. For me, I imagined it would be about collecting data, proof of concept, show that it's safe, show that it's effective, it's efficient. When I'd done all of that, by the way, because that was the challenge people set me nationally, I presented that data, and then someone put their hand up and went, yeah, but all the patients will hate it. You need to ask the patients what they think. So there I was, back to square one again. I went back. Of course, we did a review and we asked all the patients what they thought of it, and they all thought it was great. By the way, I went back at the same meeting and presented the patient satisfaction data. Lo and behold, I don't think that persuaded many other people to change their ways. These were just sort of delaying tactics, weren't they? Kicking the can down the road. Most of the people who've embedded this now, I think, are probably people who've worked here with us, the fellows that have been through and then thought, oh, actually, this really works. Works for the hospital, it works for patients. They go back and they picked it up and they've started doing it in their own units. But I don't know what lessons there are in that for me. Just to say, it's really difficult when you really change someone's embedded practice into something completely different. That's a really challenging thing to do. Even if you've got the data and even if you've got the support of your patients and whoever else, people do have a habit of digging their heels in. And as I was told when I started to make some of these changes in my own department as a new trainee, well, not a new trainee, a first year consultant, I faced that, I was told, that's not the way we do things round here, young man. That was literally what I was told. And all I would say is, please don't suppress your young colleagues in that way, because I actually meet in my CMO role every new consultant who starts in this organization. And the first thing I ask them is, what are you going to change and do different in your department? And how can I help you make those changes? I want people have to come up with new ideas. We have to go against the convention in a sense, in a tried and tested and sensible way. And that's why that's one of our values in this organization, always improving. I reflect on my really negative experiences, both locally and nationally, how difficult it was to make some of those changes. And I've switched all the way around to going, how can I support everyone to do things like this differently? The people who've been training, Mohamed, as you well know, have worked in different units and different environments and have got all the great ideas. They're the people with the great ideas.
Yes. Okay. So I literally had a question on the list to point out what you mentioned about, this is the way that we do things here, because one of the biggest challenges when you go to a new unit, especially for trainees, is like, okay, do whatever you're told to do. That's how things are being done. Don't try to challenge the system. That's kind of the usual feedback that you get. But again, how do you do in these situations, especially for trainees? Because I mean, as a consultant, you might have a little bit more of potential to make these changes, or again, the team might respect those changes that you are trying to do. But for a trainee, those changes are always questioned.
Yeah.
So how do you advise trainees about this?
I think that is tricky, and I'll give you an example of.
Yeah.
So I mentioned when you are a trainee, you work in different units, and the important thing about that to me is you'll see the same procedure done in a completely different way, won't you? In two different units, you'll see the pathways working completely differently,
Yeah.
and it's not that one is better than another; it's just different for another, and it's developed in a certain way. That personal practice of how you do your operation versus your colleague. I think
Mm.
my advice to trainees is go with the flow with some of that. In that, when I have a fellow that arrives with me, I say, look, this is the way I do this operation, and when you're doing this operation with
Mm.
me, you do need to do it my way. I'm not pretending my way is the only way or even the best way, but it's the way I've worked out that works best for me and my patients. And I actually encourage them,
Mm.
therefore, to largely take on and deliver things in the way that I do them. And that doesn't mean to
Mm.
say at the end of that period of time, they might think, oh, Mr. Grundy's way he does this operation is great. I love that bit. Or they might think that part of the operation was great, but I hate the way he does that. It doesn't work for me. So, yes, experiment and do things. There is a bit of, I'm afraid, when you work for Mr. Grundy, you have to do it Mr. Grundy's way, don't you? Equally, there'll be parts of that
Mm.
where if you're a sensible trainee, you'll be able to say, well, actually, I've had a thought, Mr. Grundy, about how there's another way of doing this. Can I show you something else? And if you've got most consultants are a reasonable bunch and will listen. They might say that's very interesting, but I don't think that worked for me. But what I would say is, having been around and tried 100 different ways of working as a trainee, you need to
Mm.
decide how you're going to work.
So let me ask you a question about what advice would you give to yourself as 20-year-old that you would love that someone gave you that advice before, when you were 20-year-old.
Oh yeah, there are lots of things. I don't have any regrets in a sense, because you can't have regrets about things that happen in your life, can you? But
Yeah.
going back, and I referred to this earlier, I would say I wish I'd known that might have embarked upon a leadership career. Value. I wish I'd had the insight to know that, and I would support people to do that. That's one thing I think,
Mm.
and the other, I don't know. I was this isn't really about doing something different, but something I was nervous about was I trained in one unit. I did all of my training in one unit. It's an excellent unit. I was very happy there. It was Bristol. It doesn't matter where it was. I think a lot of trainees will experience this now.
Mm.
You'll think, therefore, my future must be in this department, in this place. But actually, there's a whole wide world out there. And you might actually find that if you have the courage to make the jump and go somewhere else, that the opportunities for you as an individual might be much greater. But it's quite a
Mm.
big leap to make. You have family commitments, don't you? Kids in school, all those things. But
Yeah.
actually, one of the biggest things for me was spending a year in Australia, which made the break from where I'd spent 8, 9 years of my life before, and then taking a
Mm.
job in Southampton, which is not somewhere I'd worked for many, many years. Better opportunity and platform to change things than had I just stayed on in my same
Mm.
job in my same department. Not that you can't make a success of that, but if you're in that situation, I would again say to people nervous about that, embrace that opportunity, take the great ideas and the great training you've had and take
Mm.
it somewhere else. And just, you have to be flexible now, don't you? Actually, the job market is difficult, isn't it? So I would say embrace that
Absolutely.
opportunity.
Yeah.
However, it'll be difficult for a few months or a year, but ultimately you'll probably find it really, really worthwhile.
And let me finish by asking you about um, if someone like a surgeon or a neurosurgeon would like to go and develop this leadership role as early as possible in their life, or in their training, what are the actual steps that they need to do right now? Like, what can I do right now to reach to your position in terms of leadership positions in the future?
Yeah, I think the first thing to do is get yourself some hands-on experience, isn't it? And again, when I
Hmm.
look back, and I never appreciated this at the time, but if you're writing the rota, if you're designing and running the training program for your colleagues, if you're having an active role in organising and delivering services like that in a department, those are all actually opportunities, aren't they? Leading the ward rounds. We used to have a ward round structure in Bristol where you'd have someone nominated as the senior registrar. That was in the days after senior registrars had gone. But that was a leadership opportunity. You were so I would take those opportunities, and it doesn't matter how early they come. I did have some of those opportunities very early on, as a second year registrar, someone saying, well, you're the senior registrar for this week or for this month or this year. We alternate those roles. So take those opportunities. There are now many opportunities, like more formal opportunities to look out for. Some of the organise things, run ward rounds, whatever it might be, and then look for some of the national or bigger opportunities at a later stage, depending on what your ultimate ambitions might be. Not everyone needs to have done that. Not everyone needs to or wants to be an academic clinician. So look, I think it's a valid alternative to look for these things and get some experience early on, and then look for some formal training a bit later on, I would say.
Yeah, perfect. Thanks. It's wonderful advice, and I think that with the current shape of the market and the challenges happening within the NHS, I think we probably will end up having more surgeons and neurosurgeons working in parallel, like in these leadership roles, or exploring other things. Similarly to being an academic neurosurgeon, to be like a leadership neurosurgeon or something else. I don't know what is it, but we could have different rules in the future, I think.
Yeah, I was going to say that there's something in that, isn't there? Because what I appreciate, when I left most of my job to be the CMO, although I do 1 day a week, I've essentially given all of my PAs, 10 PAs, back to the department. And so off the back of that, they've been able to recruit another neurosurgeon in desperate need of a job, haven't they? So the more
that's true,
opportunities you do create for other people.
Perfect advice. Thank you, Mr. Grundy, for joining. It was a very interesting discussion. I think it creates like a toolkit for anyone who would like to get into leadership positions and learn about those skills that you need, the challenges you might face. So it's out there for anyone as a neurosurgeon or as a surgeon who would love to explore leadership positions within the NHS, explore programs and the skills that they can gain. So this podcast is for you. Thanks again for joining, and it was really interesting. For our audience out there, please watch this episode on our YouTube channel. And there are a wonderful list of guests coming up over the next few weeks. And see you. Thanks.